time we usually dodges, and at the end we may sleep. So I will try throughout the coming 25 or 30 minutes or so to keep you delegates little bit awake, and in between we will give some small doses of stimulation by some small easy questions. So without wasting much time, I'm just starting my talk on dysnatremia in children. So our outline will be grossly on normal body fluids compartments and its physiology, electrolytes, particularly the sodium homeostasis, its regulations, hypernatremia, the clinical features, how to manage, and types, hypernatremia, its clinical features, types, and how to manage. So regarding the body fluid compartment, some of the talks may be a little bit repetition of our previous talks, just like the basic physiology, which has happened on module 1, and some maybe in the case of polyuria. So we will skip that part. So not to go throughout the whole slides. We can have the important points only to be listened. So hope my arrow is also visible there. So regarding our total body fluid compartments, 2/3 of our total body weight is water, and among that 2/3 is intracellular water. So regarding 1/3 only is extracellular part, and blood volume is only 5% of that. So regarding this 60% of fluid, that's regards to an adult value. And as we know that mostly in pediatrics, particularly infants or neonates, this water value becomes very high. Total body water can be up to the tune of 80 to 90% in case of extreme premature, and gradually reduces till elderly can be as low as 50%. And this water value is low just because the amount of the extracellular fluid only, which is decreasing, the intracellular fluid more or less remains same throughout life. So this is the only part. And both the ECF and the ICF intracellular fluid compartments has some major cations and major anions. So the major cations of extracellular fluid is sodium, whereas the major cation in intracellular fluid is potassium. So today our discussion will be majorly on sodium part. So the intracellular component of sodium is minuscule, so that's why it will be ignored in most of the calculations. So sodium determines the basic extracellular fluid volume, and potassium determines the intracellular fluid volume. So only just few lines on osmolality and tonicity. Whenever this type of solutions, there are many solutes in the solution that converts to the osmolality. But like this yellow molecule solutes, not all the solutes can cross the membranes easily. So whichever molecules can cross the membranes easily, they contribute to the effective osmolality, or rather called tonicity. So whichever solutes is easily passable across the membrane, they can convert to osmolality, but didn't convert to effective osmolality or tonicity. So our main our normal human blood, the normal osmolality is made up of sodium, urea, and glucose in majority. But regarding tonicity, as urea can easily crosses across the cell membranes, so tonicity is only conferred by sodium and glucose and not by urea. And that too, the glucose tonicity will depend on the level of insulin. If the patient is insulin deficient, then glucose also becomes an ineffective osmol. So that's why tonicity will be confirmed majorly by sodium in case of insulin deficient patient also. There is also a term called osmolarity, sometimes equichangeably used by osmolarity. The only difference becomes the denominator being a volume rather than a weight, and it is less commonly used, so we are not discussing on that. So regarding this tonicity and osmolarity, remember, effective osmolarity or tonicity is most commonly used for most of the sodium homeostasis. To calculate the osmolarity, we usually use the proper formula of sodium into 2 plus glucose in milligram per dl by 18 plus blood urea nitrogen in milligram per dl by 3. This is called a calculated osmolarity because all the three values are easily available in our labs. The osmolarity can also be measured in some lab, which is called an osmometer, and that osmolarity is called usually a measured osmolarity. Many a times the calculated osmolarity can come around 290, whereas the measured osmolarity can be a bit high, around 300. So up to 8 to 10 differences is possible in case of normal human being, just because some unmeasured osmol which are not regularly measured in our routine labs. But whenever the gaps become so high, suppose in example, we are treating a patient of rest ICP with some oral or intravenous high osmolar agent like mannitol or glycerol, that time this osmolar gap will become very high. So that time we need to discuss on this osmolarity, because our body will try to keep the osmolarity round about 300 to maintain the basic physiology of all enzymes and hormones in the body. So regarding electrolyte balance, the major electrolytes helps for the myocardial function, the neurological function, the excitement, the fluid balance, and the acid-base balance. Obviously, sodium is the major contributor for the extracellular cations, and the major organ that determines the homeostasis of sodium and other electrolytes are basically kidneys. Regarding sodium, also the adrenals, the hypophysis, and our heart does help as per our requirements in our further slides. So sodium is the major cation. The amount is more or less kept in a tight range of 140 plus minus 5 in a normal scenarios. But whenever there is some dysnatremia, either hyponatremia or hypernatremia, the values get changed. And it is not an uncommon scenario because hyponatremia itself is at least 10 to 40% common in case of different hospital settings. As per settings, the value gets changed. Suppose we are using it in case of a PICU settings, the chances of hyponatremia can be up to the tune of 45%. So this is not to be ignored because many a times this is a milder case only and may not be clinically implicant, but sometimes it causes a standalone separate morbidity and mortality. So the serum and plasma, these two values are usually interchangeably used by our common clinical setting. We'll come to the differences also. And the hyponatremia has been graded as mild, moderate, and severe. Less than 135 is a mild hyponatremia, and between 130 to 120 is the moderate one. So again, this hyponatremia, other than its severity, can be classified as per its onset, duration of onset also. So if it is more than 2 days or 48 hours old, it is called as chronic. If it is less than 48 hours old, it is called acute. Why to know the difference? Because in case of acute disease, the shifting from the intracellular fluids gets varies. We'll come to our further slides. It is possible that 80% of the sodium can get shifted when there is acute losses. Whereas in chronic losses, only 60% of the sodium can get shifted from the intracellular compartment. We'll come to a case discussion later on also when we see. So suppose a small question like that I told, we can have some interaction with the delegates, and if the delegates have some queries, they can put in the chat box. So I will pass through this question. Which of these parameters is primarily sensed by cerebral osmoreceptors? Our options are blood pressure, effective circulatory volume, tonicity, all of the three. So we can wait for at least 8 to 10 seconds like this and can see the chat box if somebody can answer in the chat box itself. So this is just a stimulating question because our next 4 or 5 slides will be on these topics only, how the sodium is being regulated by 2 major pathways. So participant can give their answer in the chat box also if it is feasible. Otherwise, we will take the answer at the end. So moving towards the major regulatory factors of these cerebral osmoreceptors, sodium is being managed basically by RAS system, the renin, angiotensin, aldosterone system, also the pituitary hypophysis system. So coming to the first system, the RAS system, it all starts with an, suppose the blood osmolarity, the effective circulatory volume in the afferent and efferent vessels in the kidneys are low. That time the juxtaglomerular apparatus, they senses the low osmolarity volume, they secretes the renin from the JGs, from the juxtaglomerular cells, which is nothing but an modified cells of the different arterioles of the glomerulus. And this renin helps to convert the angiotensin secreted from the liver to angiotensin 1. I know this is a quite complex graph, so not all the points to be remembered, only the key points to be remembered here. This angiotensin 1 is converted to angiotensin 2 by the help of ACE enzymes coming from lung. This angiotensin 2 has 5 actions. The major action is on aldosterone secretion from the adrenal cortex. And this aldosterone helps the body to retain the sodium as well as water from the lead distal collecting tubules. The angiotensin 2 can also directly absorb the sodium and water to increase the blood volume and blood pressure. They can cause direct sympathetic activities to cause vasoconstriction also. And to some extent, they can also help in ADH, antidiuretic hormone secretions, which helps in only pure free water absorption and not any sodium absorption. So by all these 5 methods, our RAS system will try to bring up our volume and osmolarity and tonicity of our body by retaining sodium and water from usually most of the time from the lead distal collecting tubules. So now coming to the JG cells in nutshell, because we have discussed all this physiology in the basic physiology chapter also. So this is just a mere repetition. So in this JG cells in the juxtaglomerular apparatus, where the distal conductive tubules returns back to its own glomerular capillaries, the afferent capillaries here has been converted into JG cells, juxtaglomerular cells, which is the basic secretor for the renin. And who senses when to secrete the renin or not? This is the afferent arterioles, where the cells are more cuboidal, more densely packed. They are called the macula densa. They not only sense the effective volume, they basically sense the sodium chloride concentration in the fluid passing through this DCT. And once the sodium chloride concentration drops, there is a huge amount of secretions of renin from these JG cells, and which goes to act on the angiotensin RAS system. So regarding these JG cells, their main target is to increase the volume of body's blood volume by absorbing sodium and water. So coming to the second system of the important part of sodium homeostasis, this is through the hypothalamic osmoreceptor system. Here, whenever we have some increased water intake, our blood osmolality or effective osmolality goes down, and that time the ADH secretion from the posterior pituitary get blocks. What does ADH normally do? It causes free water reabsorption from the collecting duct itself without any sodium changes, without any sodium reabsorption. So for that reason, whenever ADH get blocks, huge amount of free water diuresis happens, and again our blood volume, body water volume, and also the goes down, and our tonicity increase again. That time this circle has been cut down, and so that's why our ADH secretion stopped whenever the cerebral osmoreceptor senses that the body osmolality is now increasing due to water diuresis. At that time, the reverse happens. ADH starts secretion. There is increased amount of water antidiuresis from the electricity, from the collecting ducts, and the osmolality remains within a static of around 300, 290 to 300 by this by this mechanism. So there are, other than this osmotic stimulus, there are also some non-osmotic stimulus like pain or stress or some infection, which is quite common in our critically sick patients who are admitted in our ward. So whatever is a normal physiological ADH policy, the normal physiological water and sodium demands for a normal person may not be same just like a hospital admitted patient, because they are on stress, they are having an altered ADH secretion in comparison to normal patient. That has to be kept in mind when to decide on for normal physiological fluid and electrolytes intake versus hospitalized patient routine fluid and sodium intake. So this is the another picture of the how the ADH acts properly in the collecting duct. So here the ADH basically works through the ABP receptors here, the ABP2 receptors. These ABP receptors, upon stimulating with the ADH hormones, they open some water channels. They are also called aquaporin 2 channels. And these aquaporin 2 channels can endosize to the water. They goes to this is the lead density cells. This is the luminal side. This right side is the basal part. I think the arrow is visible. I'm not sorry if it's not. And then these aquaporin channels push the water from the luminal side to the basal side. And then again, this channel gets free. And this cycle continues. So whenever this ABP2 receptors is damaged or the aquaporin receptors are damaged, that time this ADH is unable to act. And that is the main physiology of nephrogenic diabetes insipidus, where this ADH can't act and the water absorption is diminished. So that's why there is huge free water diuresis. And that can be due to either ABP receptor defects. They are more common. They are X-linked recessive phenomenon. And other things can be some aquaporin defects. They are a little bit less common. They are usually autosomal recessive type, and 20% of the patients have such type of defects. A little bit difference on the both things are, again, as the ABP receptors are defective, the water diuresis is defective first. And also second, the vasopressor, whenever we give vasopressin challenge to this patient, the vasoconstriction action of the vasopressor will not be exhibited due to ABP defect. But if a patient of DI is less commonly affected, suppose a female girl with autosomal recessive of aquaporin 2 defect, they will not show a good diminished in urine output on vasopressin channels because the water diuresis part is defective, just like ABP. But in contrary to ABP, these patients can cause similar vasoconstriction and increase in BP. So when before the time of genetics, when the genetics are not that common, that time also giving a vasopressin challenge stage for an nephrogenic DI, sometimes a transient hike in the BP can indicate a little bit to us that it may be a type of aquaporin 2 defect rather than ABP defect in case of girl child. So coming to our answer of that cerebral osmoreceptors, they are basically affected by tonicity and not the volume. So most of the other receptors of osmoreceptors and water reception are affected by mostly effective volume, just like the afferent glomerular arterioles, wherever the JG cells are, the macular density there, it is by the effective circulating volume. The carotid and aortic sinus, where from the sympathetic discharges are being given, they are also affected by effective circulatory volume. And also our atria, where from the atrial natriuretic peptide are being secreted whenever our body volume is increased. So all are mostly affected by effective circulatory volume, except cerebral osmoreceptors, which is mostly stimulated by the tonicity. So coming to pseudohyponatremia, next, again, as I already told, that usually serum and plasma sodium we used interchangeably. But in some cases, that thing can be a little bit difficult and different, because most of the lab does serum osmolality because it is done more easily by an indirect ion selective electrodes, which is mostly available in most of our labs in India. But for few patients, just like in hyperlipidemia or hyperproteinemia or paraproteinemia, these patients may have some difference in the plasma value versus the serum sodium values. How so? Suppose here in the right lower panel, we have two patients example. Patient A is having a normal patient with normal lipid content, has a hematocrit of 45, have a plasma volume of 55, and a cholesterol of suppose 100. So his plasma sodium is also 150 and serum sodium is also 150. The green color is noted by the sodium. So in the right side of the panel, the B patient is having the hematocrit same as 45, but here the cholesterol is, in spite of 100, it is 1000 because this is a patient of hypercholesteremia. So now the water content of the plasma is diminished and proportionally the sodium has also diminished. So plasma sodium will not be changed, but when we calculate it as a serum sodium, it will consider whole of the lipid as well as the plasma as well as the lipid portion as a denominator. So serum sodium will be falsely low. It will be around 100. Suppose it is just an example. So in case of paraproteinemia or in some hyperlipidemia, the serum sodium can falsely become low or pseudo-hyponatremia. But if you are doing a plasma sodium by direct ion selective method, which is sometimes done in our ABG machines, if they are well calibrated, then it will show the standard report. So coming to the types of hyponatremia now. So whenever we get a patient with sodium level less than 135, that is called hyponatremia, we have to decide it is mild, moderate, or severe. Second question, it is a acute or chronic, less than 48 hours or more than 48 hours. Then what is the type of this system? So as we already told, that can be isoosmolar one or a hypoosmolar one. Isoosmolar means suppose a patient with diabetes with a blood glucose of 500. So it will increase the blood osmolarity. So body will try to keep our osmolarity around 300. So that's why it will, for a protection, it will drop the serum sodium level and make the osmolarity 300. So this is one of the isoosmolar example of high glucose intake. Other example we have already just discussed about pseudohyponatremia in case of primary hypercholesteremia, etc. The most important one is hypoosmolar hyponatremia, where the sodium is virtually low, and then we have to assess the volume status of this person. The volume status can be possibly high, just like in case of heart failure patient, where there is a huge amount of fluid in the body and there is dilutional hyponatremia. So second is euvolumic. Just classical example is SIADH, or syndrome of inappropriate ADH or secretions, where we know that there is a water retention, but most of the water goes into the cell. So there was no edema actual because the fluids does not retain within the interstitial space. And third being hypovolumic hyponatremia, where fluid and sodium is being lost. It can be lost from the kidney itself, like in case of relaticular acidosis or diuretic use, and or that can be external losses like diarrhea or burn. How to difference between them? So we can do a urinary sodium. If the urine sodium is high, then the loss is through kidney by RTA or diuretic use. If the urine sodium is less than 20 milligram per liter, then the loss is probably by external organ like diarrhea or burn or cystic fibrosis, etc. So how to classify these things? So that's why we need three parameters. One is blood osmolarity, one is urine osmolarity, another is urine sodium. Many a times these three are not readily available in our ward. So we need to give some other clinical impression also. But saying so, the most common scenarios of hyponatremia in our day-to-day work practice is iatrogenic. Why so? Just because of the maintenance IV fluid we are using, because previously we are very much happy and used to use the hypotonic saline just like Isolite P, N/5D5 or half DNS as a maintenance regular fluid. Times has been changed. So now people are moving towards DNS as a normal startup IV fluid for a normal patient, a hospitalized patient. So regarding this investigation, now coming to the normal maintenance fluid, as I already told, 10 years back when we have read that time for infancy, the choice of physiological IV fluid was N/5D5, also called the Isolite P. And for more post-infancy, throughout the whole pediatric age group, it was half DNS. Then the times has changed. The fluid become in infancy half DNS and post-infancy it become DNS. But why this change required? Because most of the time in clinical scenario, it was shown that those people are getting this fluid on a regular maintenance for a prolonged time are having more hyponatremia rather than eunatremia or hyponatremia. So that's why the current standard practice is postnatal age group, every child should be treated with DNS on day 1 only. From day 2 onwards, the type of fluid will depend on his blood sodium levels, intake output, weight, etc. So the clinical features for hyponatremia, if it is an acute one, the clinical features can be little bit subtle, like nausea, malaise, headache, when there is a milder one. And if it is a severe one, that can become lethargy, obtundation, and seizure. But this is very non-specific features because most of the time, both hyponatremia and hypernatremia may mimic some similar features. And that can be common in other cases of other neurological disorders also. So the chronic changes are again more challenging to diagnose because they are very much subtle and many a times are unrecognized in our day-to-day practice, like fatigue, irritability, and less commonly some acute condition. So whenever we found some other features, like there is a tenting of skin, that means the loss of fluid is from the interstitial space. If there is a sunken eyeballs, then maybe the loss of fluid is from transcellular fluid. And if the BP is falling or there is a cool extremities, then probably the plasma volume is being lost. So again, or just a recap, if the intercellular space is being hyperloaded, then it causes edema. If it is underloaded, it's called dehydration. If the second vascular space is overloaded, it is called heart failure. If it is underloaded, it is called shock. So both the things of edema and dehydration cannot coexist. Similarly, heart failure and dehydration cannot, and hypovolemia cannot coexist, but edema and hypovolemia can coexist. And the classic example is nephrotic syndrome, who is undergoing underfill theory. So how to estimate dehydration for a child? We are not going into calculation, just the formula that to calculate dehydration, we need to know the pre-illness weight. We have to minus how much weightless is there. And now we have to calculate the dehydration percentage. Suppose the 8 kilo child is now 7 kilo, then 1 liter of fluid loss. If the pre-illness weight is not known, then we have to go by the either clinical formula of mild, moderate, and severe dehydration and hypovolemia, and 5%, 10%, and 15% accordingly. Regarding hyponatremia correction of fluid deficits, there are 4 components of deficits. A total something fluid has been lost along with electrolytes, equal amount of sodium. There can be some excess amount of sodium lost in case of hyponatremia. They are called solute loss, solute deficit. There can be excess amount of free fluid loss without sodium, that is called free water deficit in case of hyponatremia. How to calculate that? That will, in the next talk, Kamran sir will deal with this. Remember, if the correction is over a chronic one more than 2 days, then 60% of the fluid is lost from the ICF, from the ECF. And ICF sodium we are not calculating at all because it is not clinically significant. So this is a correction methods of hyponatremic dehydration. I'm not going into the details. This is the older method given in older version of Harriet-Lane. The recent changes are only the sodium requirement, which was 3 milligram per 100 ml for a long back year, now has been changed to 14 to 15 milliequivalent per 100 ml as per current scenario, as because our regular physiological fluid intake has also been changed. So we can go through the whole formula that in our next talk we can see. Otherwise, there are, for easy equation in our ward, what we do, we can use the 3% saline whenever the sodium drops between less than 125, but never go a rapid correction of 8 to 10 per day, milliequivalent per day. And in case of SIDH, we usually go for a little bit fluid restriction at the first step. And if it is an acute one representing with seizure, then only we use 3% saline for the treatment of SIADH. Regarding AKI, if there is hypovolemia, this becomes sometimes a standalone indication for starting renal replacement therapy, either HT or PD, because dysnatremia of anything which is not correctable by medications or unable to treat by medications are standalone indication for dialysis. Now coming to the therapy part, as per the division, if it is a hypervolemic one, our treatment will be fluid restriction and maybe given Lasix or any diuretics. If it is an SIDH one, our treatment was initially fluid restriction, and if it is fails, then only 3% saline. For regarding our hypovolemic dehydration, then our target will be isotonic fluid plus added sodium. Now coming to hypernatremia in very short, because our time, we are running short of time. So hyponatremia, as we already told earlier also, hyponatremia or hypernatremia are not primary per se defect of sodium, because body has a huge capability to balance this sodium intake. Whenever we intake more, body will lose more. Unless our excretion capability is disturbed, mechanism is disturbed, only a increased amount of water or decreased amount of water can causes more often this hyponatremia problem. And these curves also shows the same, that from starting from 20 microequivalent to up to 300 microequivalent of sodium intake remains our body blood levels of sodium same by the composition mechanism. The intake, wherever you are giving a more salt charges, either oral or IV to a patient, if the excretion modality is not correct, then only the patient will suffer from hypernatremia. And the mechanism will be how this defense is being done. It's through the ANP, active natriuretic peptide. Whenever there is an increased sodium intake, the water intake is being increased by the ANP, and the decreased RAS system where the sodium is more excreted to the kidney. So coming to the clinical features of hyponatremia, just maybe looks like a same slide repetition, because as I told, hyponatremia and hypernatremia, many of the features are similar in the acute phases and in the milder phases. So it's difficult to differentiate between that. Saying the same, muscle twitching, vomiting, dehydration, fever are some specific that can sometimes points toward hyponatremia. And in some infant who are suffering from diabetes insipidus or other causes of hyponatremia, they sometimes can have a high pitch cry, tachypnea, and per se other symptoms of their primary illness. So for chronic diseases, the features are again subtle, and many of them are primarily mixed by the disorder, because hyponatremia or hypernatremia mostly happen in patients with CNS disorders only. So the features are due to their primary disorder of CNS or due to dysnatremia. It is many a times difficult to assess. So we have to rely on the blood levels many a times. But not a single value, but a trend of the blood levels is most important. Hypernatremia is also, we have to divide as per the volume status. That can be hypovolemic, isovolemic, or hypervolemic. Regarding hypovolemic hypernatremia, the losses are from the kidneys, like use of Lasix or other diuretics. So that time urine sodium will be very high. The losses can be external, like diarrhea, high volume diarrhea. That can be the urine sodium will be low. If it is hyponatremia with isovolemia, the classical example is initial part of diabetes insipidus, where later on hypovolemia sets in. And if it is hypervolemia associated with high sodium, that time probably there is some oral or IV ingestion of high sodium gain, just like treating the child with raised ICP with hypertonic saline for a long time duration. So now coming to the how to differentiate this point. So for that thing, we again need.
Sumantra, can we stop here?
Sir, one
Can you
slide
just summarize?
One slide more, sir. Only one slide more. So the hypernatremia symptoms are more common in case of preterm child, up to the tune of 40%, but in case of pediatrics, it is up to 5% only. So regarding this preterm and the extreme preterm child, they are most causes of hypernatremia is being initial fluid loss up to the tune of 15% on day 1, which usually happens up to 2 to 3% in case of term child. And obviously the immaturity of the kidney, because their countercurrent mechanism in the medullary osmolality is not working well, so that they cannot preserve their sodium and water well, and their extra losses causes this hypernatremia. So for those children, particularly vulnerable child, we need to have a serial monitoring of serum sodium, daily strictly intake output, and their weight gain if it is possible. So this hypernatremia calculation again will be dealt with our next topic. So for this reason, hypernatremia is basically treated as per the calculation, or many a time in our day-to-day ward, we give 1.5 times of the regular fluid with a less amount of tonicity of fluid, either N/3 or N/4. Regarding if it is associated with an AKI, we may land up in doing dialysis to treat this hypernatremia. So for this time, so we have to keep in mind that a single value of sodium or any electrolytes doesn't make much sense. A serial has to be followed, and treatment has to be individualized as per their volume status, their loss, type of loss, and their primary disorders, just like hypovolemic, hypervolemic, or isovolemic, and then we need to treat. And we have to regularly monitor the child as per their blood levels and clinically as per their weight, height, blood pressures, and their weight gain. So after this, I thank you, my slides. I am closing it, and I take this opportunity to welcome all my delegates for our next National Pediatric Nephrology Conference, ISPN-Con, that has been going to happen in Kolkata 1 week before the Durga Puja at October. And there are good 4 workshops. Among them, KRT workshops are basically done for the residents. So residents, if they are interested, they can go to the ISPN-Con website and register themselves. So I take my permission from my chairperson, and I'm stopping my slide sharing. Can I stop, sir?
Yes,
sir,
Sumantra, thank you.
Yes, sir.
Thank you.
Thank you.
Thank you, Sumantra.
Thank you, sir.
Thank you for a comprehensive talk. We'll now go to some case discussions, and I'm happy to introduce Professor Kamran Afzal. And Kamran is an excellent teacher, which I'm sure you'll all understand. And I'm sure he's going to be able to discuss these patients and try to emphasize the key points in the management. Kamran, over to you.
Thank you, sir, for the kind introduction. I'll be discussing today some of the cases in the management of dysnatremias. Before I begin, let me tell you that in the management of dysnatremias, whether hyper or hyponatremia, the basic principle that we follow is to estimate the fluid requirement for the patient, both the deficit as well as the maintenance requirements. Then we estimate the maintenance sodium needs, and based on this, we determine the fluid of choice to be administered and the period over which this has to be administered. So this principle will be followed both for management of patients with hyper as well as hyponatremia. But regardless of the sodium value, the first thing that we need to look at is whether the patient has any evidence of circulatory failure. If that is the case, then we need to treat hypotension. So remember, treatment of hypotension always takes precedence over correction of any sodium values. And that you are all aware, we can achieve easily by giving normal saline in the form of 20 ml per kg boluses. we may use 2 or even 3 boluses. So more dilute solutions of N/2 or N/5 dextrose saline, they can be used only once the hypotension part has been corrected. Now, Dr. Sumantra talked to you about the adaptive responses of the brain. So we'll briefly discuss these very important diagrams to understand why we need to be slow in our management of chronic hypernatremia. So in a normal brain with normal osmolarity, once hypernatremia sets in, before I go into this, just remember that I think Dr. Sumantra also alluded to this, that sodium disturbances are primarily disturbances of water balance. So hypernatremia chiefly is a state of dehydration, and hyponatremia most often is a state of overhydration. So in a patient with hypernatremia, because of increased tonicity in the extracellular compartment, there is loss from the brain parenchyma. And this, within minutes, there is a rapid adaptation that happens wherein there is accumulation of electrolytes within the brain parenchyma to counter the extracellular fluid tonicity. Now, however, these electrolytes must return to their original place, and over days, there is a slow adaptation mechanism that takes place wherein organic osmolytes are generated within the brain to counter the hypertonicity in the extracellular fluid. Now, once this has happened, which usually takes place around 2 to 3 days after the onset of hypernatremia, then rapid correction of hypernatremia should always be avoided, because the tonicity in both the extra and the intracellular compartment now is balanced and high. So if we are to reduce the tonicity in the extracellular compartment fast by a rapid correction, then the fluid is going to shift into the brain, resulting in cerebral edema with all its neurological consequences. Hence, hypernatremia that is chronic in nature should always be corrected slowly. Now, these are some of the infusates and their sodium content. Normal saline or 0.9% saline has around 154 milliequivalents per liter, while Ringer's lactate has 130 and 3% saline has around 513 milliequivalents per liter of sodium. 5% dextrose, as you are aware, has no sodium. Also, it is important to understand that 5% dextrose has all free water, while normal saline has no free water because it is isotonic to the plasma. It has no free water. Now, this has consequences when we are treating patients with hypernatremia, because you cannot give 5% dextrose because it's all free water. And remember, hypernatremia develops because there is too much loss of water and less loss of sodium. That means free water or solute less water is lost, and that is resulting in elevated levels of sodium. And the correction of this sodium also will be by replenishing the free water deficit. So 5% dextrose is not a fluid to be used in patients with hypernatremia because it would result in a very precipitous fall in the sodium concentration. Now, before I go to the methods for hypernatremia, the fluid and electrolyte measurements, the important thing to remember is in all these methods, the numbers that you would come to is almost the same. So it's the choice depends on how you want to correct it, and the ease, whichever method you find easy, you can use. So in all these methods, the basic principle is that we need to replace we need to give the maintenance requirements. Plus, we also have to give the solute water deficit. That means water that is lost because of dehydration along with solutes. And in addition, we need to give the free water deficit. That means the extra water that is lost without any loss of sodium, which has finally resulted in elevated levels of sodium or hypernatremia. So in all the methods, the basic principle is the same. In the first method, there are 3 steps that you can follow. The first is that you estimate the volume and sodium deficit. So as already discussed in the previous talk, you can assess the volume deficit either clinically, but if you have the pre-illness weight, you can simply look at the difference in weight to assess at the volume deficit. Now, sodium losses can be calculated by multiplying the serum sodium with the proportion lost from the extracellular compartment. So you use a factor of 0.6 and the amount of fluid deficit. Okay, so we'll see how we calculate the fluid deficit. So for example, somebody has lost 1 liter. So 1 into 0.6 into 145, that would be the amount of sodium lost in that particular case. Now, the free water deficit is the chief reason why the sodium has actually gone up. And this is what we will need to replace to get the sodium levels down. So 4 ml per kg of free water is generally required to get a sodium decline by 1 milliequivalent per liter, which means that if you want to get a decline of something like something more, then you multiply the 4 into weight by the actual amount that needs to be the decline in the sodium. So for example, if you have a measured sodium of say 155, then the difference between 155 and 145 is 10. So you multiply 4 into the weight of the patient into 10, and that gives you the amount of free water that you need to replace to get the sodium down. And finally, in step 3, we also measure the maintenance fluid and the electrolytes. And we know that nowadays we are using, we're not using hypotonic fluid for maintenance purposes. And not to forget that the ongoing losses must also be taken into account to replenish. Now, how do we give all this fluid, the fluid that we have measured, the deficit fluid, the maintenance fluid, and the ongoing losses? Now, the maintenance fluid obviously has to be given over the 24-hour period, but in the deficit fluid, the solute fluid can also be given within 24 hours. But the fluid that is actually going to produce the fall in sodium is the free water. So we replace only half of the free water in the first 24 hours and leave the remaining half for the next 24 hours. And this will allow a more gradual fall in the sodium. So we avoid dropping sodium by more than 10 milliequivalents per liter per day. And therefore, the correction should take place over a period of 2 days or more. Now, having said this, you need to monitor the serum sodium values frequently in order to adjust the fluid that you are giving so that you do not have a very fast or very slow fall in the sodium values. Now, taking this case with a 7 kg infant with a 10% dehydration and a sodium value of 160, his illness weight is 6.3 kg. That means the 24-hour maintenance for this patient would be 100 ml per kg. So you get 700 ml. You add 3 milligrams per kg of sodium, and you add 2 milligrams per kg of potassium. The volume deficit, since he is 10% dehydrated, the volume deficit would be 100 ml per kg. That is again 700 ml. But had this been isonatremic dehydration, all this volume would be a solute containing volume that would have been lost. But since this is a hypernatremic dehydration, there is some amount of free water loss along with some amount of solute fluid deficit. So we need to calculate how much of free water loss has happened and how much of it is to be replaced to get the decline. So this value of sodium is 160, and we need to get it down to 145. The weight of the patient is 7, so we multiply 4 into 7 into 15, so you get a value of 420. The remainder of the fluid, 700 minus 420, that's a solute fluid that you need to do. Now, how much sodium is there in this solute fluid? As Dr. Sumantra pointed out, that the sodium deficit can be calculated by the volume of the fluid, which is 0.28 liters, multiplied by the proportion that is lost from the extracellular compartment, which is 0.6, multiplied by the normal serum sodium, which is 145. That means this 280 ml of solute fluid must contain 24 milliequivalents of sodium. If you add all this up together, I'm just skipping potassium at the moment, just because we are discussing sodium. So if you add all these fluid together, you have 1400 ml of fluid and about 45 milliequivalents of sodium. But we do not want to give all this fluid together because it would result in a more rapid fall in sodium. Therefore, we give the maintenance fluid for the 24 hours, but of the deficit 700 ml fluid, we give only half of the water deficit, which was 420. So we're giving only 210, and we give all the solute fluid. So if you add this all up together, this will amount to around 1200 ml of fluid and 45 milliequivalents of sodium, which means that this 1200 ml has to be given to a fluid which is something like a N/4 in 5% dextrose. On the second day, we give the remaining free water deficit, again 210 ml with the maintenance fluid, which means that now we can give a more dilute fluid like N/5 saline along with potassium. Remember that ongoing losses must also be added to the fluid that has to be given. So the second correction method is that you decide upon the fluid that you need to give and then calculate how much of sodium loss would be expected if you use 1 liter of that fluid. So if you use 1 liter of a fluid that contains X amount of sodium in it, then the difference of the sodium in the infusate minus the plasma sodium divided by the total body water plus 1 gives you the change in sodium that would happen with 1 liter of this infusate. Now, total body water is calculated as 0.6 into body weight. If your infusate has potassium, then of course you add sodium and potassium and get a difference with the serum sodium. So which fluid to be used? Now we use hypotonic fluid unless there is a circulatory compromise, of course. But remember that very hypotonic fluids are not safe. More hypotonic the fluid, more rapid would be the fall in sodium. Therefore, depending on the sodium values, you need to have a fluid that is less, that has less sodium concentration than the plasma sodium concentration, but not the gap has not to be too much. So the choice of fluid could be for circulatory failure, we use isotonic fluid, but for GI losses, something like N/2 initially would be okay. For diarrhea, you could use ORS, but for diabetes insipidus, you could use more dilute fluid along with desmopressin. And of course, for renal failure, you need to resort to kidney replacement therapy. For patients with solute overload, like sodium toxicity or sodium overload, you may use diuretics along with electrolyte-free fluid. Coming back to the same patient that we discussed, using this second method, the body weight, the total body water of this patient would be 0.6 into his weight, which is 4.2 liters. So 4.2 plus 1 gives you 5.2. Now, if I decide to use N/4 to correct this dehydration, then 1 liter of N/4, now N/4 contains around 38 milliequivalents of sodium. So 1 liter of N/4 would be able to reduce the sodium by 24 milliequivalents. However, we do not want to reduce the sodium in a day by 24 milliequivalents. Therefore, if we want to get a fall of 10 milliequivalents instead of 24, we get 10 upon 15. And so, 10 upon 25. So you will be using around 420 ml of N/4. And this 420 ml of N/4 would contain around 14 milliequivalents of sodium. Of course, the maintenance sodium is around 21 milliequivalents. So the total amount of fluid that we need is 700 plus 420, which is 1120 ml. And the total amount of sodium is 21 plus 14, which is 35 milliequivalents. So we are roughly coming to the same figure of 1100 to 1200 ml with N/4 in 5% dextrose solution for replenishment. The third method, which is more easy and doesn't require any calculations, is to first replenish the intravascular volume with boluses of normal saline. And depending on the sodium levels, we decide on the duration over which we have to give this fluid. So we may use a fluid like N/3 or N/4 in D5 to start with, and add potassium unless it is contraindicated. So the urine is established, we can even add potassium to this. And we simply increase the fluid rate to 1.25 to 1.5 times the maintenance and give it over the period of 24 hours or longer, depending on the level of serum sodium. Here, you do not need to do any calculations, but the only thing you need to do is monitor the serum sodium very frequently. And if there are more rapid falls, you use a less dilute fluid. And if there is a more precipitous, if there is a slower fall, you can reduce the sodium content of the infusate. Now, here you have a newborn who is a 9-day-old. He's a 39-week gestation with a birth weight of 3.24 kg. Born normally and discharged after 12 hours. He was exclusively breastfed, and he reported back on day 9 with history of poor circ, irritability, and decreased urine volume. The mother gave a history of poor lactation. The baby was sick with cold extremities, lethargic, with labored breathing and chest retractions. He had a doughy abdominal skin. which is a significant indicator that the patient has a serious hypernatremia. His weight was found to be 2.3 with a 29% dehydration. And we found that this patient had a high urea and creatinine, and the sodium levels were 167. So in this case, the difference between the birth weight and the admission weight was around, so he had lost around 940 grams. So the volume deficit was around 940 ml. We decided that we would use N/2 DNS in this patient, and we use about 1.25 times the maintenance fluid of N/2 DNS along with antibiotics, and the sodium over the days showed a gradual fall. The KFT improved, and the baby regained the birth weight and was discharged on day 4 of admission. So hypernatremia, remember, we do not use isotonic fluid simply because it has no free water. It is not suitable for, except in patients with hemodynamic compromise, isotonic fluid is not the appropriate fluid for correction of hypernatremia. We avoid rapid correction of hypernatremia because of the risk of cerebral edema, as I have discussed. And the more important thing is we need to ensure the correction of ongoing fluid losses and continuous reassessment to recalibrate our fluid being administered. For hyponatremia, as in hypernatremia, we again calculate the fluid and maintenance sodium deficit, and we determine the fluid of our choice. Again, as in hypernatremia, the correction for chronic hyponatremia should be slow because there is a risk of central pontine demyelination or myelinolysis. Here again, there is a brain adaptive response that develops over a longer period of time in the event the patient has hypotonic state. So when you have a hypotonic state, the immediate effect is that the water moves into the brain, resulting in the swelling of the brain. This is countered by loss of electrolytes into the extracellular compartment within hours, but needs to be taken over by loss of organic osmolytes, so that the low osmolarity in the extracellular compartment is balanced by low osmolarity in the intracellular compartment. Now, in this situation, if we correct the hyponatremia fast, this would result in movement of water from the brain parenchyma, which has a lower osmolarity outside, and this will result in a osmotic demyelination syndrome, which is called a central pontine myelinolysis. In this case, this results from a rapid correction of chronic hyponatremia and usually results 2 to 7 days after the correction. These patients often have mutism and dysarthria, and more serious cases may develop ataxia and quadriplegia, or sometimes even pseudobulbar palsy and seizures and hypotension. This central pontine myelinosis is more often associated with patients who have chronic liver disorders or severe malnutrition. And often, if it is not corrected in time, it may become irreversible. Now, the treatment for asymptomatic hyponatremia requires simply correction of the volume status. As Dr. Sumantra pointed out, that you look at the volume status of the patient, whether he is hypo or U or hypervolemic. So in a hypovolemic hyponatremia, we simply restore the IV volume by giving isotonic saline. The sodium and water, you can assess the water deficit, and the sodium deficit can be assessed by using this equation, where 0.6 into body weight into, this is the desired level that we target, 130, minus the measured sodium. This will give you the amount of sodium that is required to be replaced. For euvolemic or isovolemic hyponatremia, most often seen in patients with SIADH, we simply need to restrict the fluid, and sometimes maybe we may need to give furosemide. For patients with water intoxication, again, we need to limit the water intake. For hypervolemic states, where edema-like states where you have CHF and nephrotic syndrome, then we need to both restrict water as well as sodium. And of course, for renal failure, dialysis would be required. For symptomatic hyponatremia, we need to give 3% saline. Remember, normal saline is not the fluid to be given for raising the serum sodium levels in patients with symptomatic hyponatremia. It's only 3% saline that should be used for this purpose. Now, this 3% saline has around 513 milliequivalents per liter of sodium. The idea is that we need to raise the serum sodium by 5 milliequivalents per liter by administering around 3 to 5 ml per kg of this hypertonic saline over 1 to 2 hour period. If the symptoms resolve in this period, we discontinue the infusion. Else, if you find that the sodium has raised by 8 to 10 milliequivalents or has reached around 125 or 130 milliequivalents per liter, again, we discontinue the infusion. So this is one method that we give it as an infusion, the whole volume over 1 to 2 hours, and then we reassess our sodium and also look at the symptomatically. The second method is to give this volume in aliquots of 2 ml per kg and see the response. So we give 2 ml per kg over 10 minutes and see the response, and maybe we may repeat it again once or maybe even twice. Again, the endpoint is to the symptom patient should become symptom free, or you have already raised the serum sodium by a factor of around 10. That's where you need to stop giving further 3% saline. Remember that if you have raised the serum sodium by around 5 to 6 millimoles per liter, because patients with hyponatremia coming to you with CNS symptoms are also patients who have other CNS disorders concomitantly. So it is sometimes difficult to differentiate. For example, if you have a patient with neurotuberculosis who has SIADH, then you do not know whether the seizures are resulting because of hyponatremic state or because of the primary brain pathology. In that case, if the patient is seizing, you can give 2 ml per kg over 10 minutes 2 or 3 times. And if you have documented a rise in the plasma sodium concentration by 5 to 6 millimoles per liter, and still the patient continues to be symptomatic, then hyponatremia per se cannot be responsible for this encephalopathy, and you should look for other reasons. So if you have a 6-year male child here who has a fever for 5 days and headache for 3 days, on physical examination, he has a pulse rate of 100 and he shows neck rigidity. He is diagnosed as a case of acute bacterial meningitis. His plasma sodium values are low. His plasma osmolarity is low and urine osmolarity is 210. His spot urine sodium is 30 milliequivalents per liter. So in this case, this patient has symptoms for around 5 days. So this is the chronic hyponatremia. It's normovolemic because we do not find any features suggestive of dehydration. And it is hyposmolar because we find that the plasma osmolarity is reduced. And this is a typical case where you have SIADH as the responsible reason for hyponatremia. And the treatment, of course, is to limit the maintenance fluid to 2/3 and monitor the sodium subsequently. Now, the syndrome of inappropriate ADH is a state where you have hyponatremia along with low plasma osmolarity, but the urine is inappropriately concentrated. Although the urine osmolarity is still less than the plasma osmolarity, but it isn't maximally diluted. Because in a low osmolarity state, you would expect the urine to be very dilute. In this case, the urine osmolarity is still more than 100 millimoles per kg. These patients also have high urinary sodium, and this is chiefly because the expanded volume state because of SIADH results in decrease in the aldosterone and elevated levels of high ANP, as discussed by Dr. Sumantra. This is the reason why these patients will have high levels of urinary sodium exceeding 20 milliequivalents per liter. They are not hypovolemic. There is no edematous states. And of course, these patients must, the diagnosis will requires that patient doesn't have any other systems like adrenal or renal involvement. There are several causes for this condition, but there are a lot of non-osmotic stimuli like pain, nausea, and vomiting, and which are very common in pediatric patients, particularly critically ill patients. Since we do not have facilities for osmolarity measurement in most places, just look at the blood urea nitrogen and you can measure the urinary sodium values. So if you find that the blood urea nitrogen is elevated and the sodiums are low, this suggests more likely hypovolemia and makes the diagnosis of SIADH less likely. A closely related condition is called as cerebral salt wasting, which is also associated with hyponatremia, and natriuresis is also there in the setting often of CNS disorders, but this is associated with hypovolemia, unlike SIADH, where the volume is either normal or expanded. In cerebral salt wasting, the volume is depleted. Therefore, recognizing or differentiating between these two conditions is important because the treatment of the two things are poles apart. While in SIADH, you need to restrict fluid. In cerebral salt wasting syndrome, you need to give fluids. The mechanism for cerebral salt wasting is not clear, but probably because of release of brain dendritic peptide by injured brain. And often it is also believed that it is because of the impaired sympathetic neural input. Whatever the reason, there is an increase in the urinary sodium, which results in the decreased extracellular fluid volume. And the reduced effective arterial volume results in activation of baroreceptors that result in overstimulation of AVP secretion. So despite the hyposmolarity, it's because the volume is contracted, which activates the baroreceptors. AVP secretion is high in these conditions. So the treatment for cerebral salt wasting is to give fluid and sodium supplements, and sometimes you may need to give hydrocortisone to return the volume to normal. So the basic difference, if you see, between SIADH and cerebral salt wasting is that cerebral salt wasting is a state where you have low extracellular fluid volume, a high urinary output. So the CVP, central venous pressures, are low, but they both have high sodium concentrations, and features suggestive of low volume is a high aldosterone state is also seen in patients with cerebral salt wasting. Last case is a 6-year-old post-operative case who has a pre-illness weight of 20 kg and has been ill for 5 days. He developed seizures, which were reported with IV midazolam, and he has then more seizures. His current weight is around 18.5, so he has lost about 1.5 kg. He shows some signs of dehydration. His serum sodium is 118 and his blood urea creatinines are 14.8. This type of hyponatremia, if you see, the duration is around 5 days. It's likely to be a chronic hyponatremia. It is symptomatic because the patient is presenting to you with seizures, and there are features of dehydration, so it's a hypovolemic hyponatremia. The treatment for this condition, because he's symptomatic, you need to give 3% boluses, 3% saline, and if there are more, then you can repeat this. So once we have done this, then once we are given the second bolus, you must measure the serum sodium. So we measure the serum sodium and find that the serum sodium is 125. The seizures have now aborted. So what do we do now? Now the values of sodium is quite modest, and it might even correct on its own. But if you need to calculate how to go about replacing correcting this sodium 125 milliequivalents per liter, this is the table which shows the solute water deficit. That means this patient is in some dehydration, so you need to give 1500 ml of fluid. And as we calculated solute water by 0.6 into the volume of the fluid, which is 1.5 liters into 145. So the sodium of the this solute fluid is 130. Now, as in hypernatremia, there was more of free water loss, which resulted in elevated levels of sodium. Here, you have excess solute deficit. That means you have lost excess of sodium than water, and that is why the patient has developed hyponatremia. So this excess solute can be calculated by the amount needed to raise it back to the target sodium value of 130. So 0.6 into weight, which is 20 into 5, so 60. So the total deficit in sodium is 130 plus 60, which is 190. And the total volume is 1500. And then you add this to the maintenance volume, and then you get the 24-hour fluid that has to be given. So this means that you need to give a total of 3 liters of fluid as a N/2 saline in 5% dextrose with added potassium. And you also need to replace the ongoing losses, just to make sure that the losses do not trigger a very rapid rise in sodium. Since why we have used a factor of only 5 here is because we have already raised it up to 125 by giving 3% saline. And so in a day, you should not raise more than 10 or 12 milliequivalents. So now we are raising it up only by 5. In this case, of course, 130 is the target anyway, so we need to raise it up to 130. So we give the maintenance plus half of the deficit in the first 8 hours and the remaining in the next 16 hours. So the points to remember in management of hyponatremia is that mild asymptomatic hyponatremia, once the fluid volume has been restored, can be managed simply with fluid restriction. Symptomatic hyponatremia is an emergency and should be managed as such by giving hypertonic saline. Remember that 0.9% sodium chloride is not the appropriate fluid for treating hyponatremic encephalopathy, and a rapid correction can precipitate central pontine myeloanalysis, and therefore the correction must be slow. Thank you.
Thank you, Dr. Kamran and Samantra, for excellent talks. There were some questions, and we'll try to address some of these questions. One question, Kamran, that is repeatedly being asked is that for a patient who is sick and hyponatremic, so your broad guideline is that would you begin with hypotonic solutions, and people are worried, using N/3 or N/4 in a hypernatremic child who is sick. So what, could you just re-emphasize what you just said during your talk?
See, the fluid that you start with depends on the level of sodium. So if the sodium levels are very high, like 170 or something, normal saline would also be a fluid to start with. And that is true, as we have seen in the case that I discussed, that in the initial period, it's always better to start with a infusate that has higher sodium rather than very low sodiums. So in the initial period, after correcting for restoring the volume, we use fluids that are less hypotonic, and it's only in the later part we can introduce things like N/3 and N/4 saline. So if you have very high values of sodium, it's better to start with a isotonic fluid like normal saline, and then you can switch to more dilute fluids later.
So I hope that the message is clear, that for patients who are sick, where you have very high sodiums, perhaps one could begin with isotonic solution to begin with, and later shift to a lower solution. So, Dr. Kamran, when would you consider using ORS? Suppose you have got a patient who's hypernatremic, who's otherwise conscious. Would ORS do the same thing?
Yes, sir. In patients with who are conscious and are able to take orally, ORS is a reasonable replacement fluid to give, and because in most patients the homeostatic mechanisms are in place, so giving ORS for correction of hypernatremia would result in a same effect rather than giving. So IV correction should always be attempted in patients where oral rehydration is not possible. And that is true for anything. Even for maintenance fluid, we don't prefer it unless the patient is not able to take orally.
So, Sumantra, there was a question that you have already answered. Is N/3 or N/4 readily available, or do we need to tailor make? And how would you tailor make?
Mostly it is tailor-made, sir. So it's very rarely available. Some composition of dextrose plus 3%. N/2 is available, but N/3 and N/4 the definite question. Sometimes D5 and N/3 are rarely some manufacturers are making in India, but mostly in our day-to-day world, we are during emergency we are making it either by using a standard saline that is easily available 0.9% saline, along with some sterile water or distilled water which is available. But usually you have to make a big volume. So many times we try pricking the 10 ml pouch of injections, that becomes so messy and that invites infection. It's always better to have a sterile water of a bottle. They are usually available in the pharmacy. And parallelly, some normal saline, suppose 100 ml of normal saline and 200 ml of sterile water, that makes an N/3 solution. But that asepsis has to be taken care of, sir.
You can,
Okay.
Can I say something?
Sorry, Dr. Kamran, you're saying something, yeah.
We can even just use 100 ml of 3% dextrose of 3% saline in 5% dextrose would also produce an N/3 solution. So if you have a 500 ml bottle of 5% dextrose, you can add 50 ml of 3% saline and you get a N/3 solution.
Yeah, that's a good option. Sumantra, what does D5 water mean?
D5 sir, only sodium free. Only sodium free is dextrose, but these are really, as Kamran sir also told, that mostly due to rapid drop of sodium, we fears to give only 5% dextrose to a patient of hypernatremia. But many a times it may happen that we are treating with N/3 and N/4 for 5 to 6 hours. The sodium is not dropping and the patient continues seizing. That time we go down to our sodium concentration to N/5, maybe N/6, and rarely can we try for an sodium free fluid, but in that case we need to repeat the sodium every 4 to 5 hours just to check there is no rapid drop in the sodium concentration. That is the only fear. That's why we usually don't use the sodium free fluid, that is 5D, upfront for a patient of hypernatremia.
So, Dr. Kamran, why does glucose not contribute to tonicity?
I think Dr. Sumantra discussed this.
So can I take the question?
Yeah, sure. Please take. Yeah.
So glucose confers to the tonicity and sodium confers to the tonicity, not urea, but glucose is passes the membrane only if there is insulin. It has some restriction to passing the membrane. So if there is a insulin deficiency majorly, then glucose can easily cross the membrane and its conference to the tonicity is little bit less. So it is not a major contributor if our body levels of insulin falls down, just in case of IDDM. And the example which was given was a case of IDDM, probably a cystinosis patient who is having diabetes in younger age. And for that child, major contribution of the tonicity is by sodium, not by glucose.
Okay. So there was, all right. Thank you. And again, whatever glucose that comes in, also gets metabolized. So finally, there's a rapid metabolism of glucose per se. So clearly, finally, does not change the tonicity very much. There's another question, Dr. Kamran. Suppose you need to empirically decide between managing hypernatremia with N/2 or N/3 or N/4. What would be your choice? Suppose you need to take an empiric call. The skin is doughy. You know that the sodium levels are high. What would be a safe volume to use and how much? We have already discussed that, but just to re-emphasize, there's a question with regards to that.
If you have a serious levels of sodium, that means more than 160, then it's always better to use a less dilute fluid. So you can use N/2 in that situation. It's only later that you can switch to N/3 or N/4. And the volume, of course, if you're using maintenance volume, 1.25 to 1.5 times of the maintenance can be good volume to start with.
Okay. Yeah. So what you said 1.25 to 1.5 times maintenance and begin with N/2, and perhaps you can come down to N/3. How
Yeah.
frequently would you be monitoring serum sodiums in a patient with marked hyponatremia or hypernatremia that you are managing? Sumantra.
Sir, usually literature says it should be at least every 5 to 6 hourly if we are attempting with a much hypoosmolar fluid and we are expecting a rapid drop. Otherwise, if the situation doesn't permit, at least 12 hourly monitoring is necessary. But we need to follow the trend on the same lab. Either many times it happens that lab reports come late and blood gas reports come fast. But the blood gas is not standardized. If a blood gas method is standardized, then the reports are jolly well reliable. But we have to follow only one trend, either VVG, blood gas versus blood gas, or lab versus lab, at least at 12 hourly fashion. And if we are apprehensive of some rapid fall, then maybe preferably 6 hourly fashion.
I totally agree with you. Sumantra, again, a question for you. Some people use only plain water through NG tube for free water deficit. Are you fine with that?
As Kamala-san already told that if the child is stable and does not require IV fluid, then we can correct with ORS, that low osmolarity ORS. Many a time we'll end up if there is no such expected drop after a 12 hours, the sodium is not dropping still, but the child is still GCS wise okay. We can try at least double dilution of ORS sometimes, because the osmolarity then becomes at least half of the low osmolarity ORS. And even if we fail on that low osmolarity, then we can try for free water. Only use of free water at first line or at least at second line probably is not preferable. Maybe a third line choice.
Yeah. So be careful, and as Dr. Kamran said, for somebody who's conscious, somebody who's accepting orally and so on, I would be cautious giving plain water through an NG tube to a child who's comatose. I would definitely be cautious. I would rather use fluids intravenously. Kamran, is that right?
Yes, sir. I absolutely agree with you, sir.
Because we don't want somebody with having problems. Kamran, a tough question: how to deal with hypernatremia induced by 3% saline given for raised ICP, and now the patient also has acute kidney injury?
I think that's a tough state when you have a renal failure with hypernatremia. I think dialysis is probably the safest way to get it down.
So any precautions so when would you consider dialysis? Suppose you have a child who's not having frank acute kidney injury, but who has a sodium of say 200. Would there be any specific indication to dialyze, but say reasonable output? Imagine a central DI or a nephrogenic DI with a sodium of 200. He's still passing urine. Would you prefer to do dialysis, or would you rather maybe just manage without dialysis?
If the patient still has a reasonable amount of renal function, then even rehydration, for example, newborn patients with hypernatremia often lands up in such scenarios. We see at 2 or 3 weeks of age, babies having values 200 and above. And in that situation, simply giving IV replacement alone and not resorting to dialysis helps, and you can do away with that. But patients where you are unable to give volume, for example, renal failure with oliguria, in that situation, or patients with heart failure, for example, in those situations, renal replacement therapy remains the option.
Any precautions while doing dialysis in these patients, Sumantra?
Yes, sir. So first thing, if the patient is our first line of medical treatment fails, then dialysis. Otherwise, we are unable to treat with our medical preference. That is 1.5 times. As Kamran told, either the oliguric patient for AKI or having heart failure, we can't give not even more fluid, not even 80% fluid also. That time, if we are doing a dialysis, either for smaller baby for a peritoneal dialysis, we will try, suppose the patient having a sodium of 180 or 180, then our standard PD fluid contains a sodium of 135. We can attempt to make an increased concentration of the PD fluid by injecting 3% saline, so that the gap between the patient's blood level and the PD fluid can be maximum 10 or 15, like this 165 versus 180. We can treat with this, so that's why no rapid drop of serum sodium happens within a day. Similarly, with hemodialysis, we can adjust the dialyzed sodium a little bit up to plus minus 10 with some machines of Fresenius and some other brands also. So we can dialyze with a little bit higher sodium, that's up to 145 or 150 with a hypernatremic child. And if the urea creatinine per se is not that bad, we can attempt at least initial a long time dialysis over a prolonged time, not to make an acute shift within a 1 hour of duration. That we can attempt. But in PD, the attempt is a bit easy because we can hike up our dialyzed sodium to any level. But in hemodialysis, most of the time we are limited to up to one extent.
Okay, thank you. We will not talk about the water deprivation test. It's been discussed before. So, if there are any other questions, yeah, somebody could just ask as well, Or Jitendra, if we also need to do the quiz, and I think we are already running short of time. Jitendra, can we close now?
Yes, sir.
Yeah.
Thank you, sir.
Okay.
Uh,
Okay. Thank you.
Ankita,
Thank you so
can
much,
you please?
Kamran and Sumantra, for
Thank
excellent
you, sir.
talks,
Thank you very much.
and for your very clear cases and clear directions. Thank you very much. Jitendra, you can take over, please.